Check, check.
Thinking about it, you have playing for basketball when you see
I did get my bag. Thank you. Very nice. Right. So Oh, yeah.
Yeah.
Absolutely.
Oh, yeah. Right.
Yeah, another one really.
Yeah, so.
My mother.
Yeah. Mag, yeah. It says Mag.
Oh, yeah. I know. I think it was absolutely hysterical.
Right.
Yeah, it's like a little preschool one.
I mean, people are like.
Look lovely. Oh, thank you, as you. Thank you. Jonathan. Yeah, I know, I know. No, actually, it's nice to not wear yoga pants. Like, oh, I need a break. Right, I need a.
Good afternoon. I love all the chatter and everyone meeting and greeting and catching up. It's wonderful to hear the energy in the room. Welcome to the March meeting of TCB. And I would just like to say that we have a lot ahead of us today. And so we should get started. There's so much we need to learn and hear about. And I wanted to welcome back Representative Exum. And she'll be with us to listen and get up to speed. And I just want to say how grateful I am she's here with us. And Claudia, would you like to?
Sure. I'll just also echo, it feels like we're a full family again, and I just can't wait to dig into today's presentation. We have so fortunate to have OHS present on a study they did on behavioral health parity, and I get the privilege of introducing two of my colleagues and coworkers at OPM that are doing work related to holistic planning on autism and IDDD. So excited about today and eager to jump in.
Right. Good afternoon, everybody. My name is Erica Nowakowski, Executive Director of the Tau Youth Justice Institute. And just a couple of housekeeping in regards to if you have, which I'm getting ready to turn mine on. So I'm going to mute myself on Zoom raising of the hand and so forth for questions. Also, if you do enter your questions into the Zoom chat, my staff will continue to monitor the questions and make sure that we get it to the appropriate, to the chair so that, but we may not get to all the questions, but we will try our very best to respond to your questions. And before we get into anything else further, we do need to call for acceptance of the minutes for February. And just to acknowledge that we did receive some corrections and my staff did send out the corrected meeting minutes from February. So those have been reflected in the new version that has been sent out.
So moved.
Wait a second. Yeah. Okay. Thank you. And just a few other housekeeping for today in regards to an update on the operationalization of the TCB committee. We are very excited to announce a couple of things. As you may recall, we had a survey, we administered a survey a few months back regarding work groups. And we introduced 4 work groups. One of them was the infrastructure work group, the services work group, the school-based work group, as well as the prevention. There is a strategic planning, but that's very short-lived and it's going to take place this summer. But with that being said, we did have some chairs that were appointed, and we had the opportunity to meet with the chairs for infrastructure, which is Alice Forrester and Jason Lang, as well as the chairs for the services work group, Edith Boyle and Jan Pansen. And we are met to discuss the scheduling of when they want to meet, the frequency and so forth. And so in the handout, you will see that we're kicking off the services work group on March 13th. These work groups are held virtually. So if you are interested in joining that work group, please contact my staff. In regards to the infrastructure work group, their first meeting will be held on March 19th. From 10 to 11:30. The services work group will be March 13th from 2 to 3:30. So again, if you would like to join those work groups, please contact my staff and they will put you on the list and so that you can receive the Zoom invite. The second update is around the other two work groups that I mentioned, which is the preventions work group and the school-based work group. We will be looking for starting to conduct interviews. And so if you are, we did collect a few names earlier or late last year of people who were interested in being considered as candidates for to be co-chairs for those work groups, but that is still open. So if people are interested in being considered as candidates, again, please contact my team and submit your resume and letter of interest, and we will be sharing that with the chairs of the committee who will then conduct the interview and make the selection. Hopefully we can activate those work groups in sometime in May or June. Okay. And then the last item on the agenda here for updates is that we do want to engage. We've talked about engaging the TCB committee in the development of its strategic plan. And we hope to, as you remember, we had a one-day level setting with you all, which was very successful. And we heard a lot of positive feedback around that. We will be engaging you all again in the same location at Middlesex Community College. For a full day, one day at the beginning before the summer kicks off and so forth, to do some more brainstorming and identifying your goals and identifying strategies for how to accomplish those goals. We will gather as much feedback from you all as possible from that day. And then my team will go back and type all of that information throughout the summer and work back and forth with the co-chairs or the work groups excuse me, to refine the language that we've typed up based on your feedback, and hopefully have a draft of a strategic plan sometime in September or October for you all to review and provide further feedback on. Okay, but that date is June 3rd, Middlesex Community College. We will have a registration because we do provide, breakfast and lunch and so forth. So we will have a registration because we will need a head count so that we can accurately provide the resources you all need in the sense of printing and all of that and food. That is it for the TCB updates. Any questions around what I just shared, work groups or strategic planning day? Okay, with that being said, that is it. We do have today, as Claudio mentioned, we have a full agenda with a focus on the neurodevelopmental disorders, specifically focused on autism. And we have, I'm going to give the floor back to Claudio for an introduction to his staff.
Sure. Thanks very much, Erica. As I mentioned at the top, one of the really great aspects of last year's 5001 bill was to try to intentionally create some holistic planning around ID, DD services and autism services. I know the House made it a priority bill and the Senate was also very accommodating in making sure that apart from the operational piece, which is in our delivering of services, that we take a step back and have some holistic planning. Where are there gaps? Where are there opportunities to bring together community, different aspects of our state work and thread together a really holistic viewpoint to support people with intellectual disabilities and autism. And I am really grateful that late last year, we were able to onboard two exceptional colleagues, Heather Ferguson Hall and Tara Vines, both of which join us here remotely. And I'll just tip to them starting with Tara to talk about some of the work that we've done to reestablish the Autism Spectrum Disorder Council and the work that's underway in planning for that group. And then if she could kick it to Heather.
Thank you, Claudio. Hello, everyone. Yes, the Autism Council was moved to OPM, and we got that underway with our first meeting in January. And now we are planning for our meeting in March, which will occur on March 20th from 10 till noon at the room 1C at the LOB, and also available via Zoom. So if you are interested in attending that, that information is on the public meeting calendar, and we would welcome everybody's participation and input. So that is moving forward. And then in addition, we're working on House Bill 5001, and I'm specifically looking at the level of need and IQ statutory definitions. And I'm excited to be doing that research, and we'll be reporting out next year. Heather?
Thanks, Tara. I'm Heather Ferguson Hall, and I'm very excited to be doing this work with Tara and Claudio and Zani. It's very exciting in our overarching role to look at the continuum of programs and services that are being offered by state agencies for individuals with IDD, individuals with autism. So Tara and I work very closely because there is overlap between these communities, and also people who have co-occurring diagnoses. And so we're really looking at strengths in the existing programs, as well as there's ways to streamline services and streamline access to services, and looking at gaps as well, and really working with our sister agencies to facilitate more increased interagency coordination, which is really exciting. We've already begun on that work, which has already proved to be really exciting and fruitful. And so, as Tara said, we have two studies that we're working on right now as part of last year's 5001. And the one that I'm taking the lead on is looking at employment assistance programs for people with disabilities. And so we're looking at developing potential strategies and business incentives to increase employment opportunities for those folks. So it's, as I said, very exciting work. And with that, I will pass it back to Claudia.
Thank you,
Okay,
Eric.
perfect, thank you. And now I would like to give the floor to Commissioner Guilford on the Office of Health Strategy for the parity study.
Thank you very much. Good afternoon, everyone. I'm Deidre Gifford from the Office of Health Strategy. We are delighted to be here this afternoon to present the results of some work that OHS and our partners have been engaged on since the passage of Public Act 2247. And that is to do a study looking at payment parity for behavioral health in particular. And OHS was given the responsibility to carry out that study, and we have contracted with colleagues from Acumen who are here to present the results. And we're looking at both parity between physical and behavioral health, and a comparison between Medicaid and commercial rates.
Can I pause for 1 second? Do we have the hard copy, or are we just going to be able to follow along on the screen, and we'll
Yeah,
follow up with the hard copy afterwards to the team?
Yeah, correct. Apologize. Sorry, we didn't have enough time to print out the last copy, the hard copy.
Thank
Thank
you.
you.
Sorry.
So without further ado, I will introduce Amy Wyndham, who is with us today to present the results of our study, and look forward to conversation. Thank you.
Great, thank you. Hi, do I need to, is that okay? Amy Wyndham. I really appreciate the opportunity to be here today to share the results of our study on payment parity and behavioral health coverage in private insurance. I have going to skip a few of the slides just to try to focus the discussion. So this study was commissioned by the Office on Health Strategy. There are two components. The behavioral health coverage by private insurance study is focused on comparing reimbursement rates and service use across private insurance and Husky, and also Medicare Advantage. And the payment parity study is focused on monitoring the compliance with the federal mental health parity payment requirements. So to start the study, we conducted a review of the academic literature and the gray literature on the association between increasing reimbursement rates for behavioral health providers and their participation in both private and public insurance. I want to caveat that these findings are from the national literature, academic literature. They're not specific to Connecticut. The research shows that there has been a general decline across all insurance types in recent years, a decline in participation of behavioral health providers. And one of the most commonly discussed reasons for the declines, especially in Medicaids, has been the low levels of provider reimbursement. The research tells us that so there have been some studies to look at the association between increasing rates in Medicaid and whether or not that increases participation. And what the research finds is that it does increase access to care in Medicaid, but it's generally related to providers who already accept Medicaid taking on more patients. And there is limited evidence or mixed evidence on whether or not increasing the reimbursement rates attracts new providers into covering and accepting insurance rates. We also looked at potential approaches to expanding the behavioral health workforce. And some of these that we identified include coverage for peer support services, interstate licensing of providers, school-based healthcare, and crisis care. As most of you probably know, Connecticut does participate in interstate licensing. You've expanded access and funding for school-based healthcare, and you do have mobile crisis care available. However, Husky and Medicaid here does not cover peer support services, so coverage for peer support services would be one potential avenue for expanding the behavioral health workforce. Okay, some other approaches to attracting and retaining new workers and incentivizing providers to work in mental health shortage areas that were identified in the literature include increasing psychiatrist residency spots, implementing loan forgiveness and scholarship programs, and providing financial incentives for providers to work in underserved areas and to establish professional outreach and mentorship programs to promote behavioral health opportunities. Okay, so moving on, we compared some outcomes, some metrics across Connecticut and the other New England states. And we looked at salaries for behavioral health providers. These data are based on the Bureau of Labor Statistics, which has some limitations in that it does not include self-employed. So this is probably not representative of psychiatrists and psychologists who are self-employed, but it does cover, but it includes it's based on employer surveys. So what we see for psychiatrists, and this is clinical and counseling psychologists and school psychologists, is that based on the BLS data, the salaries for these provider types are pretty competitive across the New England states.
Amy, could you just clarify what color Connecticut is on that? Because it's very hard to
Connecticut is the light blue, and I'm sorry, I can't see.
all the way on the left.
All the way on the left. Oh, that is not a very big screen. I hope.
Amy,
Okay.
could you just read the bottom footing so that we know what it says?
Yeah, the bottom footing just is a note that says the data are from the U.S. Bureau of Labor Statistics, and also that those are based on employer surveys. So just the Connecticut is the tall bar on the left, and it's the light blue bar, and it's and basically for these three, for psychiatrists, clinical and counseling psychologists, and school psychologists, the salary rates in Connecticut are the highest or close to the highest. So looking at different provider types, and I apologize for that being small. So we also looked at different provider types. So this slide, the first set of bars is the salary rates for mental health and substance abuse social workers. And the tall bar on the left is Connecticut. And so for mental health and substance abuse social workers, Connecticut has higher average salaries compared to the other New England states. That is also the case for child, family, and school social workers, which is the second set of bars, and also for psychiatric technicians, which is on the your far right. The one type or the one category of behavioral health providers where the average salary is lower in Connecticut compared to lower than Maine, lower than Massachusetts, are substance abuse, behavioral disorder, and mental health counselors. So generally across the range of provider types, according to the BLS data, the average salaries are competitive in Connecticut, with the exception of this one category of providers, which are the substance use and mental health counselors. So that's one area that is potential opportunity to attract new workers. And even though it's just the one, the counselors provide, as we'll see in some of the later slides, counselors provide a large portion of services. So it's a very important, critical part of the behavioral health workforce. 2022. So the next set of slides, don't try to read those. just look at me and I'll try to say all the words that are important. The next set of slides, we looked at the reimbursement rates and we compare reimbursement rates for common behavioral health services across Husky, private insurance, and in some cases, Medicare Advantage. These are based on 2022 claims data from the Connecticut All Payers Claims database. So this is going to focus on a narrow range of services, but some of the most common services that are provided in outpatient settings. And I want to be very clear about the kind of what types of services that we are focused on in this study, because it is not the full range of behavioral health services. It does not cover inpatient use. So it doesn't cover all types of services, and it also does not include all sources of payments for behavioral health services. So for example, state operated behavioral health services, mobile crisis clinics, and any of the grants funded through the Department of Mental Health and Addiction Services or Department of Child and Family Services are not included. So just in terms of the methodology, again, I'll say the important words. We identified some of the more common behavioral health services that we see in the claims data. This does not represent the full range of services that may be provided, but it is some of the more common ones, particularly the ones that are more common in both private insurance and Husky. My understanding is Husky actually provides a broader range of services than individuals can sometimes get in private insurance. So, you know, I'm sharing the rates for a narrow range of services that we see in the claims data. I'm going to show rates for physicians, psychiatrists, and also for non-physician providers, including advanced practice nurses, physician assistants, social workers, counselors, and psychologists. And the rates I'm showing include the total amount paid to the provider. So it includes the amounts that are paid by the insurance company and any out-of-pocket costs. Okay. I didn't realize that the screen would be this small, and I don't know if anyone has access to the Zoom to see the slides in front of you, but this slide shows the number of claims that were billed in Husky and private insurance. Again, this is 2022 for one service, which is 1 hour psychotherapy. And as I said, this is one of the more common services provided. What you see on the left-hand side in the columns are across counselors, psychologists, social workers, and we also have results for medical clinics, which would include FQHCs or other outpatient clinics, and behavioral health clinics. You see a significant volume of services provided in both Husky and private insurance. And you see, as I mentioned before, counselors provide a large volume of these services. And so that would be an area to consider for trying to make sure the salary ranges are in line with the surrounding areas. So for the reimbursement rates, what we see for 1 hour psychotherapy is that just the rates are comparable for 1 hour psychotherapy across Husky and private insurance. And so, for example, for counselors, the average reimbursement rate is $98 for a 1 hour psychotherapy session that is billed, and it's $98 in both Husky and private insurance. And so the rates are similarly comparable across the other provider types. And also behavioral health clinics that bill directly for this service bill at a higher rate in Husky compared to private insurance. Okay, I'm gonna pause there because the numbers may be too small, but I have a few more slides that are similar to this. So I want to just pause that. So basically what I'm showing is the claim counts and the provider rates and a comparison of the reimbursement rates between Husky and private insurance for these different services that we see in the claims data. Yeah, it's okay with me.
Go ahead,
I'll
Alice.
try to.
So, there was just the phase 1 Medicaid study that came out that looks at the Medicaid rates as being in a 5-state comparison, about 126% below a 5-state comparison, like $88 million difference that providers aren't getting. So to compare it to the current Husky rates is, problematic. In current negotiations with private insurances, these rates are relatively standard, I would say, just not to disclose. But getting there is like teeth pulling. And so I don't know if there was a spread of what some of the lowest rates are and what some of the higher rates are. If this is average, that would be interesting because everyone has to negotiate their own contract with the different companies.
This is the average across all the private insurance. And let me be very clear about the private insurance that I neglected to say in the APCD. It is what's included in the APCD, the all payers claim database, are the employer base, small and large groups, and the marketplace plans, but it does not include the self-insured plans. Okay, so the APCD does not include the self-insured plans, which my understanding is they constitute about half of the total insured in the population. So just to set that, and it is averaged across all of the insurance, all of the issuers. However, the payment parity study actually, which I don't know if we'll get, which we probably won't get to today, does actually look at the individual issuers. So I want to moving on to different services. That was 1 hour psychotherapy. I guess I would say the results go a little bit downhill from there in terms of the comparability between the Husky rates and the private insurance rates. So this slide shows the rates for 45-minute psychotherapy. And what we see here with this particular service is that for the individual practitioners, counselors, psychologists, and social workers, the Husky rate is about 80% of the private insurance rate. And again, these are the rates that we actually see built in the claims data, which are comparable to the fee schedules, but this is what we actually see in the data. For 45-minute psychotherapy for the behavioral health clinics, the rate is higher. The rates paid for Husky enrollees are higher than what are paid in private insurance. This is 30-minute psychotherapy. I'm going to go a little bit faster here because the rates are essentially, the results are similar. There's fewer claims for psychotherapy. 1 hour psychotherapy is more common than the shorter timeframes, but the rates are about, in Husky, are about 80% of the private insurance rates. Okay, switching gears a little bit. Those were the individual specific behavioral health providers of psychotherapy and other counseling psychotherapy services. In looking at the rates for psychiatrists and behavioral health, advanced practice nurses, and physician assistants, we do see a little bit of a different picture. For these providers, for the medical providers, they're all medical providers, but for the psychiatrists, advanced practice nurses, physicians assistants, we look, rather than looking at, they do provide some psychotherapy services, but primarily they bill for office visits. And so these are the rates that we see for office visits. And this is where we start to see a greater divide between what is billed in Husky and in private insurance. So for a 30-minute office visit for psychiatrists, the Husky rate is $65. I don't know if you can see Does that, oh, okay, that does work. Is $65, and that is in comparison to a rate of $138 that are billed to psychiatrists and private insurance. And so the Husky rate for psychiatrists is essentially half of what is billed in private insurance. For both psychiatrists and also for the behavioral health, advanced practice nurses, and physician's assistants. For the same service, 30-minute office visits billed by behavioral health clinics, the rate is actually higher in Husky. However, you can see here, you can see that there's a significant number of claims, and these are individual claims for this service in 2022. So there is a significant volume of services provided in behavioral health clinics where the rate is comparable or actually higher for this particular service in Husky compared to private insurance. However, the rates for the billed directly by psychiatrists on a claim are significantly lower in Husky and private insurance. This is 20-minute office visits, and you see essentially the same thing. You see the rates for psychiatrists at about half the level of what's billed in private insurance, and the rates for the advanced practice nurses and physician's assistants significantly lower in Husky compared to private insurance. And so this is where we see, I think, the biggest discrepancies in the payments between private insurance and Husky. We may not get all the way through the parity study, but this is not just in behavioral health. It's the rates for the fee schedules for physicians across other specialty types is also significantly lower in Husky compared to private insurance. So this cuts across behavioral health as well as other specialties, which then also still impacts individuals with behavioral health disorders because of the access to the other specialties. You know, they have probably higher need for primary care and other specialty services as well. The breath, this just recaps the private insurance. Yeah.
If I may just ask a quick question, when looking at the provider types, why wasn't or marriage and family therapist? Is that a part of?
They are included with social workers, and I'm sorry I didn't call that out.
Okay.
So this, and I apologize for that. The social worker category includes behavior analysts and the marriage and family therapists.
So I had a quick question. In noticing these charts, one thing that stuck out to me, maybe you can help unpack this data point, is that when you consider that Medicaid is roughly 25% of the coverage type for Connecticut, and when I'm seeing the number of actual billed cases, I'm seeing them represent much more like half as opposed to private insurance would be half, and it's looks like relatively half as much as Medicaid. So how do you explain the disproportionate number of billed services in Medicaid for being a smaller amount of the coverage group in Connecticut?
So actually, this is including all of Husky, and it's including all of the private insurance that is enrolled, that is represented in the APCD. So that is not the full range. So that does not include all of the private insurance. It does not include the self-employed groups because they're not represented, and the ERISA plans are not included here. So actually, in terms of the number of enrollees in Husky versus private insurance is actually fairly comparable in terms of who's represented in the APCD data.
Okay, so that's the missing piece then, is that we aren't representing all commercial insurers. We're
That's right.
representing the 20% or so that's not regulated by the state of Connecticut, the fully insured market.
That's right.
Okay, thank you.
So this actually, I'm trying to monitor time. Yes, sure.
Before you move on to this portion of the presentation, I just wanted to say, I go back to your beginning so I don't forget. I want to strongly agree that reimbursement for peer support is a real potential to expand the workforce and to strengthen the overall system of care. It is in process, but we're still waiting for the Department of Social Services to complete its work on developing a reimbursement program for community health workers. So I just publicly want to say. I can't wait for that to happen. I also just wanted to ask about what I perceive as maybe a little bit of a limitation on the competitive salary assessment, because that will include people who are in positions that are both not compensated through reimbursement. So people who, for example, school psychologists, although there is some billing associated with that work, by and large are part of the school district budget and are not, their compensation isn't as closely linked in the same way that a community mental health clinician and a behavioral health clinic is. So in some cases, the compensation isn't linked to reimbursement. It might be kind of grant funded or district funded. And it also includes settings like the state and hospitals, which, really have different kind of payment and administrative structures. And so I wondered if you had given any thought to kind of segmenting the salaries at all?
Well, the salaries are actually from the Bureau of Labor Statistics data, and they are based on employer surveys of the salary rates. So for the salary comparison, actually those school psychologists, if they're employed by a school district, and it's based on whoever is required to pay unemployment insurance. So that's who's covered. So actually I think a lot of those workers that you're talking about actually are captured in the salary comparison, but what's missing from the salary comparison in the Bureau of Labor Statistics data are individuals who are self-employed. So I think it probably does not include psychiatrists or psychologists who are self-employed. So it probably has better coverage of counselors, social workers, et cetera, who are employed by schools or other organizations.
I think I meant more that the average might hide a distribution, some kind of inequality within that
that's
average
absolutely the
because of
case.
those very.
Yeah, and I think for that salary comparison, we were trying to look in the New England region,
Yeah.
and those are the statistics that are available to us. So I think, I was more struck by I'm more concerned about the psychiatrists, psychologists, and folks who tend to be more private practice and self-employed, not being represented there. And we don't really have statistics on those. So I
Thank
think
you.
the counselors, though, yes.
Go ahead, I'm sorry, you finish with it?
Well, I think the counselors though probably are pretty well, that's probably the group that is best represented. And so that I think is the substance abuse and mental health counselors. I think in terms of if there's ability to increase the salaries in that group, it may potentially help attract workers.
I'm sorry, can you just go back a couple slides very quickly where you had the, go back, I think that's it,
We
okay.
go way back.
No, that's good. Now you said that the FQHCs were the medical clinics?
Yes.
That's a very low number.
This is just for 1 hour psychotherapy. And so this is just what shows up in the claims. And so the billing, we put this here because we wanted to show that this is not representing all of these services that are billed across the states. But yeah, we don't see we don't see a lot of billing specifically for psychotherapy in the medical clinics, but it could be that their billing is different. So it doesn't mean that the psychotherapy isn't being covered there. And it also is probably the case that more of the office visits, we did not include office visit, the claims for office visits in these slides because we don't know what the office visits are for. It could be for anything, and we would have to do some more specific study. We could potentially, if there's interest in looking at the services that are billed in different settings, that's something we could do, but it's not covered very well.
I think in a lot of our communities, the FQHCs are the delivery. And so when you don't sort of have the number representation, it makes it look like FQHCs are not doing it, but we know that's pretty much where they are. So I just wanted to make sure I was reading that right.
That's in some of we actually are planning to look, but because I expect that they are billing more office visits than psychotherapy. And so they're providing more medical management and medication management, which would show up as an office visit, but we would need to be sure that it's for a behavioral health condition if we want to look at specifically at behavioral health services.
Do you have any idea why they would bill it that way as opposed to what it is, which is a psychotherapy session? Is it a disadvantage for one way or another?
No, I think what we see in the claims is that the psychiatrists and the medical professionals tend to use the office billing code and not because they're providing mostly medical management and medication management, and not necessarily providing counseling services.
Okay. Okay, thank you. Thank you.
Okay. You all might just need to stop me when you need to. Is there a way to make it bigger? Oh, yeah, you don't need to see me up there too. Oh, no, I need the slides. So this slide shows, this is to show some of the supply of behavioral health providers that are available to in private insurance and Husky based on claims data. And so this slide shows the number of providers per 100,000 enrollees in private insurance and in Husky. And so what you see is that so for example, for social workers and behavioral analysts and marriage family therapists combined, there are 617 providers who have billed claims per 100,000 enrollees. And so across these different provider types, you see that there's basically a greater supply of these providers in private insurance compared to Husky. And the gaps are biggest for psychologists and psychiatrists. Let's get that one. So looking in terms of the volume of services that are provided and the number of patients who are seen. The left-hand side of the slide shows the average number of enrollees per provider. So there are few, and what you see here is that in Husky, for example, if you take all of the psychiatrists who have at least one claim, then they, on average, the psychiatrists have on average 29 patients. Compared to the psychiatrists in private insurance who have only 16. Now, this again is not representing all of private insurance. It's the employer sponsored, the fully insured market. But it's basically so, and you have a fewer number of providers who are seeing patients in Husky compared to private insurance. If you look on the right-hand side, this is the average number of claims per enrollee. So of these individuals who received some level of services, you see comparable volume of services across Husky and private insurance. So Husky beneficiaries are getting a similar volume of visits and care, at least at this pretty high level. But it's being provided by a smaller, more concentrated group of providers. Okay, so now we actually get into some service use. I think I will just hit some of the highlights here. Another busy slide. But what this slide shows, this is individuals aged 12 to 17. So I think for the next set of slides, I'll focus more on the youth results than the total population, just so that I know that you have a lot more on your agenda today. So looking in the data and based on claims data for youth ages 12 to 17, we see this is the number and the percentage of individuals who have a mental health disorder diagnosis or a substance use disorder diagnosis based on the claims data. So there may be, and so we see about in Husky and in private insurance, about 26% of individuals with a mental health disorder. This is youth ages 12 to 17. And for substance use disorder, you see about 2% in Husky and a lower rate in private insurance. Okay, so this is just like in terms of the sheer number of individuals who may need treatment, this is what we're seeing. And then if we look on the right hand, the bars on the right-hand side, the percentage of individuals who receive any treatment, did that skip? Who received it, sorry, I'm trying to point and I am, there we go. This is a very low, this is not a high volume, this is in at least one outpatient visit. So this is a very coarse metric of received services. So, but you do see comparable rates of services across Husky and private insurance. With Husky, actually, individuals with Husky having about 63% of them having at least one outpatient visit or encounter for substance use disorder, and better than 86% of mental health disorder. This does include it includes all types of outpatient. It's a very broad range of outpatient treatment. So it includes office-based care, intensive outpatient, partial hospitalization, residential treatment, and medication treatment for SUD. Those are the very small words along the bottom of the slide.
Can I ask a quick
Yeah,
question?
sure.
Do any of the school-based health clinics or schools provide any substance use services, and are they included in here?
So some of the services that get billed, we can look at the location of the service on the claims, and we do see claims where the place of service is school, but I don't think that all of the school-based services are captured here. This is the adult system, and so what we see here, moving on, this is we see higher rates of mental health disorder in Husky, about 26.7% compared to 19.9% in private insurance. And then we see significantly higher rates of substance use disorder in Husky compared to at about 10%, and then only about 1% in the private insurance group. So I think that's probably about what you would expect to see. In terms of the percentage of them that get any kind of treatment. So this is not saying they receive great treatment. It's not saying that they receive a high volume of treatment, but they at least are having some encounters at a pretty high rate. Above 80% in Husky, they have some outpatient treatment. Could be very minimal, but at least they are having some encounter and some opportunity for treatment. I want to show this slide. This is Medicare Advantage. We did do most of these analyses, including Medicare Advantage, but today I focus more on Husky and private insurance. And I know this is the Children's Behavioral Health Committee, but one thing that kind of stood out to me across the analysis is that looking at ages 65 and older in your Medicare Advantage population, the percentage of individuals in this age group who are getting any outpatient services is just above 50%. So this may be something of, may not be the focus of this committee, but I do think I wanted to just share that result because there does look to be lower access to behavioral health treatment for individuals over age 65 in Medicare Advantage. I'm going to show just a couple more slides here. Another way we looked at service use in the population was to look at the number and the percentage of individuals who have either a hospitalization or an emergency department visit for a mental health disorder or a substance use disorder. So this is youth ages 6 to 19. And on the left-hand side, this shows just the trajectory of the percentage of individuals who were, this is hospitalization, who had a hospitalization for a mental health disorder, and it shows at 7. This bar here is day 7. How many of them had a follow-up treatment or follow-up visit following discharge from the hospital? And here you see actually slightly higher rates at the 7-day mark in Husky at 57.3% having a follow-up visit by day 7, and in private insurance, it's 44.5% had a follow-up visit within the 7-day range. And then it's stretching out to by day 30, it's in the, around 78, 77% in both Husky and private insurance. Substance use disorder, there are much fewer individuals in Husky in this age range with substance use disorder diagnosis. However, and that's why the line looks a little not as smooth. But here we do see higher rates of follow-up after hospitalization in private insurance compared to Husky for substance use disorder. However, just again, we may not be capturing all of the services. So it could be that these individuals are receiving some follow-up services from other programs that are not reflected in the claims. So I would not take this as gospel that, or, solid evidence that Husky has lower rates of follow-up following substance use disorder, but I would want to, I might want to take a closer look at it.
I think you just had a quick question on that. When you say follow-up after hospitalization, you mean after inpatient
Yes,
hospitalization?
after a hospitalization for a mental health disorder with a
Okay.
primary diagnosis of mental health disorder. So the time from their discharge to over the course of the next 30
So
days if they had.
So separate from, not inclusive of children that touch the ED or stay in the ED for behavioral health.
The ED visit, so this is after a hospitalization. This does not include ED visit as follow-up.
Okay, because I was going to say, I look at that data a lot, the 7-day, 30-day, and it's lower than the hospitalization data that you have. there.
Yeah, this
So
is
it's on your next
this is
slide.
follow-up after
Never mind.
ED visit. Is that it? This is follow-up after ED visit, and you're absolutely right for substance use disorder. And this is for youth ages 6 to 19 when you get your full packet. It's higher in Husky than private insurance here, and that's however, it is significantly the follow-up after emergency room. Emergency department visit is significantly lower for substance use disorder than mental health disorder.
And just to confirm, follow-up in this case means that there was a claim in the database
Yes.
of a visit
Yes.
with a provider.
Yes, that's absolutely right. So if they see a provider that doesn't bill Medicaid or doesn't bill private insurance, that would not show up here. Okay, let me just, okay, I have one more result. That has all been focused on the behavioral health, private insurance or behavioral health insurance study. We also have results on the payment parity. Okay, so what we've been looking up so far has been looking across Husky private insurance, Medicare Advantage, and comparing service use and reimbursement rates across the payers. The second study, the payment parity study, looks within Husky or within a specific private insurance issuer to see if they are paying comparable rates for behavioral health services compared to their rates for general medical services. So very quickly, cut to the chase. What we see in Husky is what I mentioned before. Husky has low reimbursement rates, particularly for physicians, across all the services, including behavioral health services. So from a parity, the federal parity requirement standard, there's no specific concern over payment parity because Husky pays comparably low rates for behavioral health services compared to general medical services. Medicare Advantage is not subject to the federal parity requirements, but we did look at this because we still want to know how they're doing. Forget about ratios, but what we see in Medicare Advantage is we do see some, looking across a really long list of services, we do see some evidence that there are some lower payments, for example, for psychiatrist services and compared to other medical specialties. We also looked, and for this analysis, which we can provide more detailed, long tables with lots of numbers, there's 7 issuers in the states that were included in the study, and 3 of them have reimbursement rates that are near, and we compare the rates to a benchmark. So 3 of the issuers in the state have rates that are kind of at the benchmark, and we don't see any parity concerns. There are 4 issuers who we're not naming today, who do have some results showing that their payments, their reimbursement for behavioral health services are not at parity or slightly lower than their reimbursement rates for general medical services. So the next steps there, it's called a warning signs analysis. We're not saying that anyone in the state is not in compliance, but we're saying that we're seeing patterns of reimbursement rates for 4 issuers in the state that we probably want to take a closer look at and work with the insurance department there. Okay, that is all I have. And Okay.
Any other questions?
I just have a
Alice.
quick one. Do you think, because the Medicaid rates have been historically kept down over the last years, sorry, giving Erica back her computer. Do you think that the private insurers sort of do a comparison themselves and say, okay, well, if Connecticut's only paying 98, we'll pay somewhere in that area? And that there isn't, a comparison of the, there isn't a 5-state parity comparison of commercial insurances and how we compare to that.
So I can't really speak for the private insurance market. I think for I think the private insurance companies tend to benchmark against the Medicare physician fee schedule. So I think their physician fees are pretty in line with Medicare fees. And they benchmark there. But I don't actually know how they establish the rates for behavioral health providers, for the non-physician behavioral health providers.
And if you were to force them to, is there a way to, there really isn't a way. If let's say a magic happens and Medicaid goes up, is there a way the state can intercede and get the commercial insurances up, or is that not
Well,
possible?
the insurance department is responsible for making sure they are in compliance with the mental health parity law. So that's the leverage that they have.
The only editorial comment I'll offer, thank you so much, Amy, for all your hard work, is that I think there is some very good news in the results that were presented in terms of some of the concerns that this committee and others have seen over the years in terms of access for members of Husky, which is we saw when there was a diagnosis that that a claim for a service was comparable between Husky and commercial insurance. We didn't see large gaps, and if you have a mental health diagnosis, that it's easy, you have a high probability of getting care if you have commercial coverage and a low probability of getting care in Husky. We did not see that in these data. And as Amy showed, some of the data about follow-up after a serious mental health condition, a hospitalization, was actually better for Husky in some cases. So I do think there's some good news embedded in this presentation about some of the access concerns that I know were behind this legislation that was passed.
Thank you.
Thank you, Amy.
Thank you. Your next guest speaker is, as we have done in the past, we like to bring to you the direct experience of a parent or a young person. And so today we have Beatrice Allen coming to speak to you as a parent with experience.
Hello. Thank you for giving me this opportunity to tell not only my story, but my husband's and my daughter's story. Sure. Okay. I work in the public health sector, and much of what drives the work is data. So I'm going to start with some data from the Autism Developmental Disabilities and Monitoring Network. I know that's a mouthful. ADDM. Stats are from 2020. At that time, 1 in 36 8-year-old children were identified with autism. This was based on tracking within 11 communities in the United States. This was at the height of the pandemic, so as we are all aware, this number could be much higher. Among 8-year-old children, boys were nearly 4 times more likely than girls to be identified with ASD. However, 2020 was the first time ADDM found the percentage of girls to be over 8%. I'm sure most of us are aware that girls are underdiagnosed for a variety of reasons. When I learned about this opportunity, I asked my daughter, who is 18, is there anything you don't want me to say about our autism experience? She said, Mom, tell the truth, tell it all. I will do my best in the next few minutes to do just that. Prior to the age of 3, my daughter seemed neurotypical. She made eye contact. She was engaged and happy. She had trouble self-soothing and didn't sleep well. We were first-time parents, and we thought that was just, part of parenthood, part of the deal. When she was a year old, I was fortunate enough to have her enrolled in the program Parents as Teachers. I received monthly visits from a parent educator who would check my daughter's milestones, and she was usually a little bit behind, but would always catch up, so birth to 3 was never suggested. When she started preschool at the age of 3, we noticed something wasn't right. We noticed around this time loud noises really bothered her. I remember being outside on the back porch and a motorcycle went by with a really loud engine, and my daughter dropped to the ground and put her hands over her ears. And I started noticing that a lot more. In preschool, the teachers noticed my daughter didn't play with the other students, no parallel play. She also had trouble sharing, and she started running away from me a lot. I called her the bolter. Towards the middle of the second year of preschool, teachers voiced their concerns that they saw some signs of autism. And so we were referred to the public school in town, and they had an early learning services and a special education preschool. And after an evaluation and an interview, my daughter was qualified for the preschool program. At age 5.5, she was officially diagnosed with autism. Along with a diagnosis, we were given 3 pages with the doctor's observations and his recommendations. This is all we received. It was up to us to navigate her care. So I went to the library and got all the books I could to find about autism. And we were fortunate enough to have a pediatrician who had personal knowledge of autism, and she gave us some direction. The preschool program was the beginning of working with our public schools. When I told my husband about this opportunity, he requested that I make sure to mention this. Having a child with autism is extremely difficult, heartbreaking, and scary. But what has been the most challenging and heartbreaking is attempting to get her a free and appropriate public education. You would hope the public school would want to make things easier, first and foremost for the child, and then for the parents. Unfortunately, our public school has made it almost impossible. When you have a child with a neurodiversity, there's a whole new language and acronyms you must learn. PPTs, IEPs, ESY, goals and objectives. You need to learn the role of each person on your child's school team and what services they are providing. And then you need to make sure that they actually provide it. Your child is not only getting homework, you're getting it as well. For the first few years, things were okay. But then the director of pupil services retired. And here's another thing you learn. You are at the mercy of the superintendent and the director of pupil services. They make the final decision on what your child will and won't receive. Things started going off the rails in 2nd grade. Classrooms were being cleared because of my daughter's behavior, but we were not aware of this. We were just told she had a rough day and she needed to be picked up early. We had our private behaviorists assist the public school teachers with implementing her behavior plan. In 2nd grade, we asked for ABA, Applied Behavioral Analysis. We were denied. Only a few weeks later, an emergency meeting was called and we were told they could no longer provide services for my daughter in the school. And they would like to outplace her to a place that provides applied behavioral analysis. Since there were only a few weeks of 2nd grade left, they felt the best way to handle my daughter was to put her with a one-on-one in a classroom by herself. And that was the start of my daughter's trauma, because she continues to this day asking, why was I put in a room by myself? My daughter has always wanted to be with her peers, to connect with people her own age. There's a misconception that people with autism don't care about connection, that they want to be alone. I have had the opportunity to know many young people with autism, and not one hasn't wanted to have a friend. You ask most parents who have a child with a neurodiversity, what they want most from them is to have a friend. My daughter has been in 3 schools before 8th grade was over, and the most effective was a private school, which we could not afford, so we had to go to mediation. Each year that she attended, we went to mediation. My husband describes mediation like this. It's like you're buying a used car with the school district negotiating the costs down from what the data and professionals recommend for services. The child is left with gaps in services, so the district can lower the budgetary impact. The parents are left to figure out a way to pay for that. It is demoralizing, exhausting, and expensive. Also, the free and appropriate education concept goes right out the window. I was asked how much we have spent on our daughter's education and therapies in the last 14 years. It's been about $150,000 to $175,000. That is not only for the therapies, but for the 2 lawyers and 5 advocates. I realize that we are extremely fortunate. The therapies she has received are ABA, speech therapy, cognitive therapy, talk therapy, medication therapy, occupational therapy, art therapy, and animal therapy. Private evaluations, special summer camps, many of those are not covered under insurance. I know it seems like a lot of therapies, and it is. I felt sometimes like I was going just one therapy to therapy. And you wonder as a parent, is it too much? Am I trying to fix my child? The problem is it's a race against time. At age 18, unless the person is severely disabled and DSS is going to support your child, or they still have an IEP and the school will pay for a transition program until age 22, neurodiverse young people are expected to go out and navigate the world. It is just not realistic, especially for the kids who went through the pandemic. My daughter was set back about 3 years emotionally from her peers. Since the pandemic, I would say it's about 5 now. My daughter is currently a senior, and she went back to her public school for her senior year. She had not been there since 2nd grade. After attending 2 different high schools, a charter school in New Haven, which was a huge disappointment and caused her extreme trauma, she then was placed in a special education private school, which was helpful because it was small, but she wasn't able to engage with her peers. So after a slow and meaningful transition, she went back to public school. We thought she had enough support and she could have some milestone moments for her senior year, like the prom, engaging in classes like pottery, fine art and theater, which is her favorite. But unfortunately, it's not a happy ending. And I wish I could end this story on a positive note, but the public school again has been nothing but disappointments. From my daughter being cut from the play 2 days prior to the show because the drama teacher did not follow her IEP, to crowded hallways, fights in the lunchroom, frequent fire drills due to vaping and lockdowns. She was not prepared for it. We were not prepared for it. We are literally holding our breath until June. She will not be graduating. She will be going on to a transition program. She will not receive her degree until the planning and placement team, which we are a part of, feels she is ready to move on to a college or a job, or she turns 22. Because she is on grade level for everything but math, she has the opportunity to attend transition programs that are located on college campuses. She has been accepted to 2 programs. We are hopeful, but of course cautious. You may have noticed I didn't really speak about myself or my husband. We really had to put the majority of our life on hold. I wasn't able to return to a paying job until 3 years ago. Prior to having my daughter, I worked in social services, so I felt comfortable advocating for my child. I am also a writer, and I wrote a play titled When Tomorrow Comes. It is a much longer version of this talk. 2 acts of what parents with neurodiverse children go through and the great fear of what will happen when you are no longer able or alive to care and protect your child. I'm aware there are now many more supports in the community for neurodiverse children and a few for neurodiverse adults. After 4 years of navigating supports for my daughter, I hope it's appropriate for me to make a few suggestions. 1, don't forget the parents. They are part of the team. Ask them how they are doing. Have support services for them. Having a neurodiverse child is scary and can be very isolating. The state of Connecticut and every state should have an updated database of support services and resources online and in paper form and in multiple languages for caregivers. It is so time consuming for a caregiver to find programs on their own. I actually work with the public health department and they are in the works to develop something like that in the community. It's called the Community Health Improvement Plan. Public health care workers and college interns are compiling this information, so it is doable. Educate the educators. Give them some more support, more information about neurodiversity, provide in-services, send them information, let them know what programs are out there to support them and their students. One more thing, I started with a statistic and I'm going to end with a statistic. Writers call it bookending. This is data from the Bureau of Justice from 2016, so it's a while ago. 2016 survey of incarcerated inmates. Data was collected by doing face-to-face interviews. Excuse me. Nearly 2 in 5, 38%, state and federal prisoners have at least one disability in 2016. The most commonly reported type of disability among both and state federal prisoners was a cognitive disability. Among all prisoners, 24% reported a doctor, psychologist, or teacher had told them at some point in their life that they had attention deficit disorder. Nearly a quarter of all prisoners reported participating in special education classes. State and federal prisoners, 38%, were about 2.5 times more likely to report a disability than adults in the general population, 15%. Not enough has been done, not enough is currently being done. As a parent with a child with more than one diagnosis, autism, ADHD, and anxiety, I'm asking for our state and our service providers to please do more. Thank you. And if I could, this is my daughter's artwork, and this is what neurodiverse people can do. They can think outside the box, and we need them. Thank you so much.
Thank you. And now we will have a Nate from the from DSS. Or is it-
I can get them seated.
Thank you. All right. Oh, hello, everyone. I'm Nate Calixto. I am the Autism Support and Resource Specialist with the State Department of Social Services, Autism Division. And just a little bit about me. I work primarily with those that have been found eligible for the autism waiver and placed on the waiting list by providing them information or resources while they remain on the wait list, resources that may be available to them to help them with whatever need it may be. So the Department of Social Services waiver for persons with autism provides home and community-based services to individuals with autism who do not have an intellectual disability. So individuals must have a full-scale IQ score of 70 or higher. Individuals must have substantial limitations in 2 or more major life activities, such as self-care, understanding and using language, learning, mobility, self-direction, and the capacity for independent living. Currently, the services provided under the waiver include behavioral health services, job coaching, community mentor, life skills coaching, social skills group, respite, assistive technology, interpreter services, specialized driving assessments, personal emergency response systems, individual goods and services, non-medical transportation, and our newest addition, January of 2023 is nutrition. Currently, the maximum waiver cap per person is $50,000. The average allotment in the calendar year of 2023 was $25,498. The waiver added 13 new providers in the calendar year of 2023, bringing the total number of providers to 151 at the end of 2023. I believe that number is now 165. Since the transition of the waiver from DDS to DSS in 2016, the waiver has grown from 3 case managers and 120 people receiving waiver services to 11 case managers and 330 people in the process of either being determined Medicaid eligible or receiving waiver services. The number of assigned cases will increase by 120 in July of 2024. So these are the age ranges of the individuals they're on the waiver. If you add them, they're going to be 326 because since I actually made this presentation, 4 have come off the waiver for a variety of reasons. They didn't want to be on the waiver, or they moved or something. So this is 326. There isn't any individuals that are 3 or under, ages 3 or under. We don't have any individuals who are ages 4 to 8. Just 37 that are between ages 9 and 17. 37 that are between ages 18 to 21. 120 individuals between the ages of 22 to 30. There's 107 individuals between the ages of 31 to 40. 15 between the ages of 41 to 50. 2 that are between the ages of 51 to 60. 8 between the ages of 61 to 70. So again, those are for the individuals who are in that onboarded onto the waiver. Oh, not too far. Yes, I did. Okay. So I've also included some information, or we've included some information on the wait lists. As you can see, more than half of the individuals on our waiting list are 21 and under. We have 18 who are ages 3 and under. We have 280 who are between the ages of 4 to 8. And I've kind of made a side note there that 101 are actually ages 5 and under. And that's as of 2016. I'm sorry, February 16th. There's 664 individuals between the ages of 9 to 17, 336 individuals between the ages of 18 to 21. 631 are between 22 years old and 30. 103 of them are between ages 31 to 40. 13 are between the ages of 41 to 50. 9 are between 51 to 60. 2 are between 61 to 70, and 2 of them are between the ages of 71 and older. So currently if you add those up, at that time, as of the 16th of February, there were 2,058 individuals on the waiting list. And we've included some data that in the calendar year of 2023, there was 144 individuals with an application date of 2023 that were added to the waiting list.
Excuse me, if I could ask, how long on average and thank you for this information, are they on the wait list?
Well, currently those onboarding onto the waiver have an application year of 2014.
Just to clarify, so that means that currently there are people who've been on the list for 10 years? Been on since 2014. And what is it that is causing that wait to be so substantial for 10 years? Yes, please.
Turn on your mic.
Oh, it turned off automatically. Did I? Okay, I didn't. Funding. The short story, short and simple, is funding. But from what I'm aware of, it could be another factor. And I don't know who the technical assistants are, but it's in process where they're trying to maybe make a two-tier system for the waiver. And I think Mike Olson can speak more on that.
We've been working with the technical assistants from CMS to try and expand the waiver, either a two-tiered waiver where people that have less needs under 25,000, so we could maybe serve a third more people. We have had.
Can you just turn on your mic so we can hear it on the recording as well?
We have had an increase. We, between fiscal year 22 and 23, we got 200 new slots for the waiver. And then we have 120 slots coming June, and then in 2026, another 200 slots. So we are growing, but it's a slow process and people are being added all along.
And one other question I have is, did you find that the $50,000 wasn't necessarily, everyone who is on the autism spectrum who may want to apply would not utilize $50,000? Right?
That's why we're looking at the
So
two-tier
that's
system.
now why you're looking at the two-tier system, because I would think it would be better to have a different amount and provide services at least, and especially understanding with autism, the need for early intervention. And then also understanding that some of the people who have the diagnosis will realize they have a greater need for different services over time. But it would seem almost a sliding scale would have been more, I guess, something that at least more people could have had services versus just having that amount allocated. So I'm just really curious why the $50,000 was the original allocation.
It was $60,000. They lowered it to 50, I want to say 3 years ago. We do have people that use that full amount depending on their needs. We have others that maybe only need a small amount of support. Again, that's why we're looking at the two-tiered system now. Why it wasn't done sooner, I can't tell you.
That was my last question, was what was the basis of the amount utilized? Because the spectrum, that is exactly what it is. That's exactly what it is. Thank you.
So, oh, sorry, was there another hand up?
Microphone.
Yeah, I'm curious. I'm sorry, please.
Just a quick question. So these are programs that keep waiting lists. I'm assuming that there are programs that don't even keep waiting lists, so this number is probably a lot higher. Am I correct in that assumption?
I would imagine.
So this is just people who applied, right?
Right, I would imagine so, right? Because CDC says 1 in 36 individuals have autism. So 2,000 is not reflective of Connecticut's population. So yeah, I would say it's only those who applied, correct?
Thank you.
You're welcome.
My question is around if the waiver is capped at 50 and the utilization is a little over 25, can you talk a little bit about why there's underutilization? Is it a workforce issue? Is it an identification issue? I mean, these are the folks that are getting it, so they're using less than they're getting. And I think that we'd like to know what are your granular observations about why services aren't being accessed? Because you have quite a menu of services.
Mm-hmm.
The services people need are being accessed. Some people just don't need that many services, but we have some people that use 3 hours of life skill support a week. So their budget's not that high, but they wouldn't be able to live alone without that 3 hours. So again, that's why we're looking at the two-tiered system. And we have other individuals that the $50,000 won't be enough if their parents weren't around to help provide support. So it varies on each person, but some people have much fewer needs, but they still have those needs.
Are there workforce issues involved?
There are some, but that would be more of the actual utilization numbers. These are the what's allocated for each person. So there is some difference in utilization where workforce does come into play.
Are there any particular populations
or geographic regions where for lack of a better term, we have a workforce desert that you guys are having to contend with?
Fairfield County has been a challenge for us. We've had a lot more individuals, but our case managers have been working with different vendors in the areas, and we've actually added, like I said, they've added 13 in the last year, and several of them have been down in that area. But it is, agencies are short-staffed, healthcare agencies are short-staffed. It is difficult.
And I noticed housing's not on the list, right? So,
Right, we do not have a housing option. We do not do placement. It is something we're looking at with the technical assistance, and maybe not just a housing option, more a tenancy support option
Right.
where.
yeah, we do. I think we had a great presentation from Massachusetts.
Correct.
And, they do some really creative support for even, I forget what it's called, allied living, where you can convert your garage into an apartment. But I wonder if that also would, increase the cost and the spend, to get closer to the 50,000 if housing was really involved. Because now there's no option at all,
Right.
So Nate, if I can just go back to Representative Exum's point, if you could give us a little bit more of a full picture on the wait list in particular, because I know a lot of our agencies maintain wait lists for various programs, and there are different dynamics that emerge. How much of a sense do we have this wait list is actually fresh and current? Do we go back often to sort of make sure people still intend and want the services? And subsequent to that, because I know in DDS, we try to triage out and have this subset of the wait list that's the emergency or emergent needs, meaning they would need and can take services that day or within a week. Do you have any sort of granularity to this wait list that tells a picture of the immediacy of the requests and how likely people are to continue to want and need these services?
I can't, can't speak on how urgent the requests are. Because speaking to parents or schools who have students that are aging out for the extended transition program, and I mean, I can go on with different scenarios. They've all feel that their particular student or child has a sense of urgency to continue some supports because either they're not going to qualify for Medicaid or they're aging out of the school district. What I could say, as far as how many individuals are on the wait list and still want to receive services, we've since 2018, not including the pandemic when we were working remotely, since we had been sending letters to the individuals on our wait list. For the purpose of this committee, they were mostly demographic verification letters, just asking for those on our wait list to verify that what we had on our wait list on file for them, like their address, their health insurance status, phone numbers, email addresses were current. So my point is, we've sent out these letters in 2018, and I actually have some data here. I'm gonna pull it up. I'm sorry. Here it is.
So it sounds like, Nate, that there's some sort of an outreach on a regular basis to keep this wait list fresh.
Yeah,
Is that what I'm understanding?
I want to tell you maybe some stats here. I know I'm on a time limit. So, for example, in 2018, there was a point back in June of 2023. Mike was taking off. Mike Olson, he's our case manager supervisor. He was onboarding the next 120 people from the wait list. And at that particular time, before HB 501 was being passed, ASDAC wanted to see how the Division of Autism was reaching out to individuals on the waiting list, and essentially help prep them with the onboarding process and whether we were providing resources to these families. So from those, only the 120 individuals at that point in time we saw that 113 out of 120 applicants, we mailed them to 2018 demographic verification letters. Out of the 7 or 3% of those individuals that we didn't mail letters to, at some point, a resource guide, which is also found on our website, was sent to them or emailed to them, or they called in and we offered them resources. In 2019, we found that 91 out of the 120 individuals were mailed these demographic verification letters. So that meant 29 weren't mailed the letters. However, 27 were mailed either a 2018 or a 2022 letter. And the last 2 remaining either received information via email or phone call related to resources found on our website, or for whatever reason they called in for. And then lastly, the 2022 and 2023 letters, out of the 120 that Mike had asked me to kind of vet and see if we reach out to them, 118 out of 120 individuals were mailed those 2022 and 2023 letters. 2 of them were not mailed. However, at some point or another, those individuals contacted the division, and they were provided information about our waiver website or information, whatever information they called in about. And I can almost feel confident that if we vetted the whole waiting list, that'd probably be the pattern. Currently, that session that I told you about between 2022 and 2023 with the mailings that we did, we did the years, the application dates or application years. We've completed all the mailings for 2014 through 2020. And what we found is that we usually get, I did a little over a quarter of the people we've mailed these letters to will respond to those demographic verification letters. So for example, 2014, there were 100. I'm not giving the actual value, I'm just saying, if there were 100, only 25 responded. And if they do, we'll send them an updated resource guide and information that they can find on our website, and I'll chat with them and see what resources they're needing. Currently, we're working on the 2021 application years. We've mailed out 22% of the applicants for that year. So currently that's 45 out of 204 people with that application year we've sent mailings to. And I'm hopeful by the end of this year, I'll go through the whole waiting list.
I think we're well over time, but there's certainly a lot of interest. So maybe a follow-up conversation or some work group. We'll invite you to the work group to do some more of a deep dive on this. Senator Mar.
Is it a really quick question?
Yes. So the legislation did a very great job of giving 200 waivers. It was a 200 or 300 waivers this last session. I think it was 300. And
320.
320. Go. And you're saying that only 25% of the list actually is, so now you've got 133 people, or whatever the number is coming on. So if you looked at 50% of moving 50% on, you could probably get more people to get those waivers, right? Do you know what I'm saying?
I'm not too clear on the question. I'm
Okay.
sorry.
It's just that if only 25% of the people coming back and answering with their demographic information, and they've been waiting since 2014, that's what you said. And right now you have 320 waivers, but only 133 coming on board, correct?
320 by 2026, but in July, the hope is to onboard in a total from now to July, a total of 120.
Okay. I'm just saying the legislation could probably pass a whole bunch more waiver numbers and get to a lesser, a more decent number.
The difference is with the mailing that he sends out, it is with the address that they have. When my case managers contact individuals, we start with the information that they previously gave. Then we use impact, which is the Medicaid database. We use other sources to find individuals because people move in 10 years.
Well, Alice, evidently I might have been the only person surprised that it was going to be fast. So I actually am going to use privilege and ask Mike a question. You mentioned that Fairfield County is a care desert. And I wonder, is it really a care desert or is it a higher identification number, therefore creating unmet need?
No, it was really a care desert. We had one agency in that area.
Thank you.
And we've added 3 more recently.
Okay, thank you so much.
Thank you. Thank you both. Okay, so just want to bring you back to the agenda. We have 2 more presentations and I'm just thinking, we're not going to get through them. And so I'm looking at, I do know an invitation was done by DSS to Caroline to come and present Jennifer Chrome. I just wonder, I'm looking at Alice and Michael. I don't know, we may have to shift you to the next month, or how would you all like to proceed? Because I know that you want to go to the provider. Okay.
No, I was going to say, do you want to like flip a coin or no, I'm kidding.
Yeah.
Yeah, Dr. Powers, maybe.
Yeah, okay.
Maybe Dr. Powers should go since.
Okay. So we'll go to the providers. Okay, we'll go to the providers. Thank you. Wherever you'd like to sit, we can navigate.
All right.
And the reason for staying together is that this is essentially a community project. The subject of a lot of discussion with probably another 5 people that weren't part of this. For starters, thanks for the invitation. I think our responsibility today is to bring this down to the ground and to talk about here's what we as clinicians and providers are contending with. I will say to start out, I've had experience with the waiver from the first year it started, and I still have that client who's on the waiver. And I have a young man who started on March 1st after being 14 years on the waiting list. So it does move along. He is now 30. So there's a lot that's gone on in those 14 years, but I'm just happy he's getting onto the waiver, that's for sure. So this is a spectrum disorder, and we understand that because the spectrum presents both opportunities and problems. It's also a quintessential neurodevelopmental disorder. There are many others, but autism is kind of the one that captures everybody's attention because it can present in so many different ways. It can present as somebody who's very disabled, and it can present as somebody who's absolutely invisible. And I think a comment was made a little bit earlier today that girls are particularly underrepresented. That's probably the understatement of the day from my perspective as somebody who sees kids on a daily basis. What we want to do is we want to talk about what exists for us as folks who are providing services. And there's 2 different agencies represented here. We don't pretend to have all the answers, but what we have done as a group, I think, is to talk about the greatest hits that we have to deal with. The areas that we see the greatest opportunity for change and where we see policy implications that we would like the legislature, but other stakeholders to consider here. You're looking at a slide that really describes an awful lot of information on a little tiny screen. I can't read anything on the left, but I know what it is because we created it. But the implications of autism range across everything from autism without ID to autism with rare genetic disorder. And the important point to drive home here is that all of that needs to be cared for and understood. It requires a lot of different clinicians to do that, but the impact on a family of having to navigate that is huge. And the problem that families run into is not only the navigation, it's finding those people. That's why I mentioned earlier care
caregiver desert or service provider desert. I think Fairfield County is one example, but I'm certainly aware of other parts of the state where I cannot find referrals for the kids that I see for any number of different services. And since we are a lifespan organization, for me to have to find somebody who understands congestive heart failure in a 61-year-old who has autism is out of state, to be honest with you. It's not in state. And I'm faculty at Yale, and I have access to some pretty smart people and good resources. So as you're listening to us, I want you to be thinking not just about the needs of the kid with autism, because this is about behavioral health. It's not just children's behavioral health. If children's behavioral health works, you have family behavioral health. If it doesn't work, you don't have family behavioral health. So if we can do the next slide, please.
So as you can see up on the screen here, the center, or the nucleus, if you will, is a family. And our parent pretty much showed us exactly how challenging it is to navigate having a child on the spectrum. These are all the things that they have to figure out. They're given a diagnosis. They're given a packet of information on the suggestions of what they should do moving forward. And then this is what they have to navigate. And as you can see just from looking at the screen, you can see how complex that looks, and how it's just mind-boggling to see just by looking at it, to then have to figure it out on your own with not a lot of assistance.
Next slide.
So one of our first challenges is to summarize is in order to get care, you need a diagnosis. And if you don't have a diagnosis, you don't get care. It's pretty plain and simple. So we need to be able to shift that. There are parents that need to get services and resources for their child, but if it's only a diagnosed based system and not a needs-based system, then that parent doesn't get access to care. Their child doesn't get access to the services and the resources they need. Ultimately, the child is left without getting any assistance to support their growth and development.
You're next.
Okay. So the next piece of this is the neurodevelopmental disorders associated with behavioral issues affect the entire family. We heard from our mom that it does. It doesn't just affect the child, it affects mom, it affects dad, it affects all the siblings if there are in the family. And so being able to create a family care or consultation plan that actually focuses in on the whole family, and we provide development codes for family care and consultation, it actually allows us to kind of wrap around the whole family and give the whole family the care that they need, not just the individual child. It gives respite to the parent. It gives care to the siblings, as well as obviously give care to the individual child who needs the services.
Great. And Jen didn't introduce herself,
Oh,
but
sorry.
Jen is our Vice President of Business Development at Clifford Beers Clinic, and she is now running ASRC, which is a very well-known autism service resource of Connecticut, merged into Clifford Beers. And we opened an autism center 2017. And I should not be speaking today, actually, but I am, because both of our clinical people who prepared this deck are actually out. So I'm doing it. But I think that this slide is the slide, if anybody knows me, essential care coordination is critical. Just as Mike helps those folks navigate the systems on the waiver, this is something, as Tammy referred to, as peer support, community health workers, care coordination, intensive care coordination. This is very critical for families and for children, and also can be helpful in looking at where the gaps are in services. The next challenge is the inadequate Medicaid rates, and we're a broken record
and commercial rates. We just saw some data, which is of interest. But as we know, the phase 1 of the Medicaid study showed that Connecticut is about 126% below a 5-state Medicaid comparison. So when you were looking at those numbers at $98, you know, you need to add 136%. And I have the next slide actually is just a diagram. Hopefully you can see it on your own deck. I can't even see it on my own. This is a transparent, clinic. God knows what that clinic is, but it is the reimbursement versus cost. So if you look at the clinical services, I'm gonna actually, I can't even see the numbers. I'm sorry. They're in this slide, big slide deck. That you'll see that the cost for a specialized service in outpatient clinical runs about $205.95. Okay, so you can say, "Al, what the heck? That's so expensive." But if you've ever paid for private insurance, you know that it's $250. Sorry, you know, from a clinic. And I have insurance, we have unions and all of the benefits of an outpatient clinic. And we receive $139 if average for a service. Okay, so you see that difference. Some clinic, APRN is costs $240 and excuse me, costs $310, and we receive about $240. So our psychiatrist $415 for this is for an hour service, and we receive $240 if we're lucky. And ADOS eval is 180 receive 183, it costs $224. Psych eval is $84 and we get it costs $224. So you see on the bottom is the loss per every unit of service we bill for autism services. And if Robert Reed is here, he's a board member of Clifford Beers, will say, let's close, he would never say this, but let's close it. What the heck is going on here, right? Our outpatient service numbers look exactly the same. So what's going on here is I have to have 60 grants from multiple places, federal, city, towns, to be able to reimburse those dollars, to be able to pay for the work that we are doing for our community. So the reality is very real and very costly for the nonprofits that are running it. All right, I'm off my soapbox. Mike.
So I'll tell you, it's also very difficult for the for-profit organizations that do this too. The non-for-profits have some advantages that the for-profits don't. Fortunately, we speak in one voice insofar as what the needs are, and we understand the population. And besides that, I like working with Alice. Now, having said that, one of the issues that we run into is workforce. It's also payment, okay? And workforce is really important, and it has multiple dimensions. But the thing I want to highlight here is something we have raised with DSS and Bill Halsey in the past, and I know he's had conversations with some folks in the legislature about this. But Connecticut's Medicaid standard for behavior techs. These are the folks who work under the direct supervision of a board certified behavior analyst who are providing direct services to a child with autism. The DSS regulations are substantially more strident. They're much more difficult than all the commercial insurers. Okay, and that seems kind of upside down, right? So in order to be able to bill, a behavior tech has to have a bachelor's degree from a university in a behavioral health field, which could include behavior analysis, plus a year of full-time equivalent working with somebody with ASD. Now, we're talking about folks who are entry-level professionals. We don't even have training programs substantial enough to train the folks who do this work in Connecticut, excuse me. And we have one of the highest concentration of board-certified behavior analysts in the country here in Connecticut, okay? Or alternatively, you can have an associate's degree with an equivalent number of credit hours with passing grades in a behavioral health field, including behavior analysis, plus 2 years full-time equivalent experience working in autism. Now, I would be very excited to have lots of those folks coming to my door. They don't exist. We can't find them. That's a workforce problem, okay? It isn't just a reimbursement issue. If we could pay twice what we pay for behavior techs, we could not recruit the number of behavior techs to address in our center the 100+ kids we have on a waiting list who are already approved by commercial insurance.
Can I just jump in real quickly? I'm sorry. Whose responsibility is to set up the standards for these techs? Is it DPH, DCF, DSS?
My understanding is, well, these are my understanding is that this is from DSS, Department of Social Services. Okay, and that's
Yes.
why I've had the conversations with Bill Halsey about that. Yeah.
DSS as the payer?
No. Well, they set the rates
They set the rate.
and the codes that can be reimbursed. We'll get to the code thing in a second.
Oh,
And the conditions.
okay. Thank you.
Yeah, sure. Thank you. And thank you for asking that because that's a big deal. Oh, and by the way, in addition to all of that, whether you go through the associates or you have the undergraduate degree, you have to have 18 hours of continuing ed in autism services in the past 3 years. Okay. None of that is required by commercial insurance. Here's the problem. We have a whole population of underserved kids. They tend to be Black and brown. They tend to live in the 5 most challenged community settings in Connecticut, and we can't provide services because we can't find the folks because of the standard. So that's one thing I just want to put on the table for you to consider. The second one, though, is the number of training programs we have for folks, either at the community college level or at the undergraduate level or the graduate level. You've seen some of the data that were shown about the number of psychiatrists and psychologists we have who are providing services. We don't have enough of them either. Okay. And we're talking outside the school systems now. Okay. And the problem that we run into is that we might have kids on a waiting list for who have Husky for a diagnostic evaluation because Husky pays about 40 cents on the dollar for what an evaluation would be from commercial insurance. We can't have situations like this and expect there to be some degree of equity and distribution of access to services for kids with autism who live in certain places under certain conditions versus people who are enfranchised differently. So the takeaway on this, and one of the things that we would encourage the legislature to be at least considering is that the funding issues are important, but so is the workforce development. And the workforce development is not just giving money, it's people have talked about forgiving loans for psychiatrists and physicians who work in certain areas. In my experience, I've never heard of that for people who go to work in autism. It's a swell idea. I wish I had it. But the point is, we need to be thinking outside the box in terms of training our workforce. And that's something I think it's important insofar as allocations towards community colleges and the universities. We happen to have a new president of the Connecticut community college system, right? Who is invested in understanding the needs of folks with autism going to post-secondary education and is working with the organization down at Southern Connecticut State University, the autism program, in conceptualizing how to do that. These are advantages to us. They're there. Jen?
So we talked about the need for expanding the workforce. Well, I'm going to talk about expanding the access for employment for those with ASD. Alice mentioned that I oversee ASRC now under Clifford Beers. And if you know anything about ASRC, you know that they have a very vibrant resource directory and resource line. I could tell you on the average, at least 3 times a week, I get a phone call from an individual who is desperately trying to work. And he can't get access to employment. No one calls back. No one looks at their resume. They don't get promotions, so on and so on. So we need to be able to figure out a way to expand inclusive employment initiatives and remove restrictions in the workforce. We have plenty of folks with ASD that are quite capable from an academic and intellectual perspective, that they could easily do many different jobs. And unfortunately, there's a lot of companies that don't seem to be able to or want to expand who they market their employment opportunities to. And so we have a lot of folks that are quite capable of doing certain jobs, and they don't even get access to being able to apply for jobs or even get a second look. So we are requesting that we enact policies promoting the expansion of inclusive employment initiatives and the elimination of access barriers, so that these folks can get access to employment. They want to work. They want to be a part of the job force. We just need to give them the access to it.
So let's talk about emergency departments and hospitals, right? The large percentage of the kids who are in the ED who are waiting, Anne is here. She could tell you in a better way than I can. We have a young man who's been in the ED for 44 days in the emergency department for now probably 54 days since last time we talked. The reality is that our kids are in the ED. They're filling up the inpatient hospital, and there's no way to transfer them out, right? There's not any place that they could go to. A family can get supports. Michael and the Children's Center many years ago did a beautiful, beautiful pilot study with ABAs at Children's Center, and then transferred those ABA folks back into the community. And I'm sorry, I don't know the name of that pilot that it was by Brisk. And that was a pilot, and it stopped. Those kinds of specialized treatments and services are very critical. So we don't have the emergency room and inpatient filled with that services. Michael.
I think that one of the, I don't know, you're still here. That was a fantastic description sort of a life so far, right? Because there's a lot more chapters to go with that. But one of the things I'm going to suppose that you and your family had to navigate was, what are the entrance and exit dates and age limitations for different services? They vary. They're all over the place. Some are 18. When can you get BRS services? When can you not get them? When are you able to finish school? Under what circumstances? You described a situation where you weren't entirely supported in how to get a transition program, or even how to find one that was going to be appropriate for your daughter. What about SSI? At what age are we supposed to get that? The problem that we have in Connecticut is that there are all kinds of access points and discharge points with different ages. One of our proposals is to consider standardizing that to make it 22, because that's when school under federal mandate ends. And if we can have something to help families say, there are things, and agencies, by the way, that will support them in care coordination. If there are points that we can begin to create a pathway, a glide path for families to access different services where we don't confuse families, that's only going to help family access. Now, let's take it down to another level, which is, what about families who aren't advantaged enough to know that they can even get those things? Okay. For babies, we have Child Find. Right? You guys have to rely, for the waiver, you have to rely on going back in data sets to find where are these individuals who might be eligible for the waiver. If we're looking a little bit differently and making this family focused, as Jen has been talking about, then one of the things we need to do is reduce the barriers to families to not only finding the programs, but accessing them at the right time so they don't lose them. It's a very different story to try to get SSI before your kid turns 18, if they have autism, than after they turn 18. There's a lot more hoops you have to jump through. And sometimes you get a lot more denials. And so our point here is, why not consider standardizing all of that to make a single glide path for families, and then making sure we have the outreach to families who may not know about them or may be disadvantaged in other ways.
We want to talk about health equity. The reality is that a child who in the BIPOC community will most likely get diagnosed at age 11 as compared to a much younger age. And that's often related to both not being identified, not being going to a pediatrician that they see the same pediatrician all the time. But also there's just a gigantic service a hole for Medicaid provide people who can provide ASD services for folks who are on Medicaid in general. Clifford Beers opened our clinic in particular to reduce that gap in age and diagnosis. And Jan and the Child Study Center has been a great partner for us. And their waiting list, I don't know what their diagnostic waiting list is, but ours now is 1 year. And we used to think, oh, we'll fix that from the Child Study Center. And now here we are at a 1 year waiting list in terms of diagnosis, which goes back to Jen's first point is until they're diagnosed, they can't get the treatment. And so we're really in a health inequity issue here that we need to increase the services, in particular specialized services for ASD and Medicaid across the board. And the other is actually really coming from folks who are seeing our kids waiting in the emergency department and waiting in the hospital because there are no group homes available for folks who live with ASD. And they're just the closures on the group homes. Clifford Beers oversees Youth Continuum. One of our group homes was closed. You know, and the reality is it could be easily adapted to be able to serve on a specialized population. And so we just have to really, as advocates, really assert for some policies that actually move towards developing services for folks who are ASD and IDD in residential across all genders, and in particular for boys. There are very few services for boys residentially. So those are our 11 points, and Michael, you wrap it up.
So what we've tried to do and what we hope to do today is to articulate priority points. There's a lot more that we could be discussing. There's a lot more needs that families have come to us as providers and said, Dr. Powers, can you help me with this? Where do I go for that? The 11 points that we raise here are significant, but to bring it back to something that we said a little bit earlier, this is not about children's behavioral health. This is really about family behavioral health. You cannot have a kid not getting services and have a family that thinks everything is just fine. It doesn't work that way. It doesn't work that way for families who have kids with many different kinds of disabilities. Our specialty happens to be in the world of autism. The call to action here, could we have the next slide? We want to leave you with a couple things. If you have been doing other things while we've been doing this presentation, just care about these points. There's about 11 of them. This is the take home. You can tell that I teach both undergraduates and graduates because this is something I actually use with my children and say, forget what I said. Here's the most important thing, and I leave it till the end because they don't usually listen until that point. Needs-based services are primary. This isn't just about diagnosis. We realize that there must be gatekeeper points in here, and diagnosis is an important one. It's a very difficult hurdle to get around when you have medically based diagnosis being required for certain kinds of treatments. But it has to be holistic and it has to be family centered. It has to be community sustainable. Alice made a very nice comment about our BRISC program. The second phase of the BRISC program was to make sure that once the kids left the ED, they went into a PTRF that knew what to do. And then when they left the PTRF, the community was prepared to resolve issues as they arose so they didn't go back to the ED. That was the point. The second thing is we have to create codes for family support. We don't have these CPT codes that are billable under Medicaid right now, and we don't have them under some commercial carriers. It's really important that family supports be incentivized in such a way that we can get families the care that they need so they can become the primary support system for their child with outside help as appropriate. We've talked a lot about increasing reimbursement rate, but particularly for care coordination. Care coordination is really the glue that holds all of these Jenga blocks together. And without it, we just can't do the job that needs to be done. Skipping ahead to the next slide because I don't want to say anything more about reimbursement because somebody will throw something. There are workforce disparities, and we have to align Medicaid rates with that. Or we're going to have the problems that we've been talking about with people not getting equitable care. We have to make sure that we can have training programs for new professionals, but we don't just create the training programs. We have to incentivize people to not only stay in the programs, but to stay in a state. This happens to be a state where people want to come to work if you work in autism, because we have such good service delivery and we have really good commercial insurance rates. The problem is we have a two-tiered system, which doesn't sound like it's going to be very fair if you're in the lower tier. The next thing about this is if we can increase employment opportunities, we will not be leaving money on the table. It's as simple as that. There are some major businesses, Pratt & Whitney being one of them, and there are others in the state that make a point of mentoring and bringing folks on the spectrum in for work activities at different levels and for different periods of time, and then sustain that over time. Large organizations throughout the United States do this. There's no reason we shouldn't be doing that. And one has to not only incentivize that, but one has to bring that message that you can have very smart people who will come to work every day, rarely take a vacation or sick day, and they will do the job probably at a level above the individual that they're working next to because they're motivated to do the work, okay? And finishing the job is one of the things that makes autism autism, okay? The last point we have here to talk, or next to the last point we have is crisis care is critical. There's no reason that somebody should sit in the ED for as many days as Alice described. I have similar examples of my patients who have been in such situations, and it's heartbreaking. Next slide, and we'll be out of here. Consider standardizing the age of access and discharge. We talked about that a little bit, but also as we move to be a more equitable, culturally sensitive, and inclusive organization, as folks who take care of people with autism, we have to make sure that we can get kids diagnosed early, wherever they come from. And your waiting list is about a year. I know at the Child Study Center, it's at least a year. In the big clinic and also in the developmental disabilities for babies clinic. And I know that at our place, we're looking at about 8 to 9 months. And we consider ourselves fortunate. CCMC is also quite stretched. This is not just a matter of we find people to do it. We have to have something to tell families once we diagnose the kids. It's real easy to say we can find out your kid has autism and here's a prescriptive set of interventions we should do. Then we have to go find the places to go do it that don't have a waiting list themselves. That's really disheartening to a parent, okay? To be on 5 waiting lists waiting for an opening. The group home issue, I'm lucky to have worked in autism for 44 years. The tricky thing for me is that I've got folks who I diagnosed when they were 3, who are now in their 40s, and they live at home and they don't want to. And their parents are aging and they don't have the personal resources and they don't have the emotional resources to continue with this. We don't have sufficient places for our folks with autism to grow up in a community. And that's a huge issue. It touches everything we've talked about today. It touches workforce, it touches accessibility to mental health services, it touches housing, and it touches the family in such a way that we are stressing siblings and we're stressing parents as they grow older too. If there are ways for us to think about doing a course correction on that, and there would be lots of different ways to think about that, we should be thinking about it, okay? You have been wonderful to listen to us. We've gone over our time. Thank you very much, and we appreciate the opportunity.
So, Dr. Powers, as a former student, I have to say I love your teaching style. So thank you very much. And when you see us, just for everyone's knowledge, when you see us talking amongst ourselves, it's because our brains are exploding with the information and we need to just like speak about how can we fix this. So I think that that's the biggest thing I want all of you to understand. We are so paying attention. It is just that it is a phenomenally huge problem across a spectrum. And so thank you all for being here and thank you for everything that you presented us with today. It is more, we're learning so much. And I apologize to those who were not able to present what they prepared, but we will bring you back at our next meeting on April 3rd. And thank you all so much for sticking in with us. Do you have anything else you'd like to?
Can I just ask really quickly, are there any states that are doing the educational training that you were talking about? Just if they are, we can talk. I just want to know, is anybody doing that?
Massachusetts does a pretty good job as a lifespan consideration, which is really important. Certain counties in Maryland, particularly Montgomery County,
Okay.
Fairfax County, Virginia,
You gave me two. That's good.
North Carolina,
Thank you.
and
Thank
they're
you very
great
much.
places to visit.
All right. Thank you, everybody.